It is a privilege to introduce our keynote speaker this evening, Dr. Maselis. While the motor symptoms of Parkinson's, of which you are all too keenly aware, such as tremor, rigidity, slowness of movement, problems with balance, are very well known, it is only within the last few years that the attention of researchers and clinicians has shifted to the less understood non-motor symptoms such as fatigue, constipation, pain, and depression, to name only a few. These to date have been under-recognized and poorly treated. On this same note, it was originally thought that cognitive changes, or changes in memory, thinking, and learning, were not experienced in Parkinson's. And while the commonly seen deficits in memory and attention and problem solving are part of the non-motor symptoms that are not well understood, these symptoms are very disabling and in many patients are the most troubling symptoms. Thus the reason behind the decision for tonight's topic, mind, mood, and memory. Dr. Maselis is going to talk to us tonight about the latest developments in these important issues. He obtained his Master's of Science in Pharmacology from the University of Toronto in 1997, completed his medical training at U of T in 2001, and obtained his fellowship with FRCPC in neurology in 2006. He has completed a clinical research fellowship in cognitive neurology. He is an associate scientist in the Brain Sciences Research Program at Sunnybrook Research Institute, and is a research scientist in neurogenetics section at the Center for Addiction and Mental Health. He is a cognitive neurologist in the Division of Neurology at Sunnybrook and has expertise in the management of Parkinson's-related dementia as well. Dr. Maselis receives research support from Parkinson's Society Canada and the Canadian Institutes of Health Research. His research expertise is in understanding the underlying causes of cognitive impairment associated with Parkinson's disease, as well as their related disorders. And in addition to this, he has an understanding about the different effects of drugs across people living with Parkinson's. I think you will agree, having heard all this about him, that Dr. Maselis is well suited to discuss tonight's topic with us. Please join me in welcoming Dr. Maselis.
So I'm going to talk about mind, moods, and memory, the hidden challenge of Parkinson's. And I'd just like to acknowledge the research support from the Parkinson's Society of Canada, as well as the Canadian Institutes of Health Research. And in fact, this is in research that's being supported to try to understand cognitive impairment associated with Parkinson's disease. So everyone hear me okay? So I'm just going to first go over the objectives of the talk today. So first we're going to briefly review features of Parkinson's disease and a group of related disorders, particularly that fall under the spectrum of what's called Lewy body disease. We're going to review the underlying brain changes that can be seen in Parkinson's disease in the early stages, and then changes that occur in the later stages of the disease with respect to Parkinson's, but also that occur in early stages of disease when we're talking about a related condition called Lewy body dementia or Lewy body disease. We're going to talk a little bit about the chemistry changes in the brain that occurs as well. Then we'll talk a little bit about the treatment strategies that can be used to help improve individuals suffering from this group of disorders, with a focus on the behavior and thinking as opposed to the motor symptoms, which traditionally have gotten most of the interest in the past. There's going to be a recurrent theme throughout this talk tonight, and I like to demonstrate this theme by looking at the corners of a triangle. In the lower half of the triangle, we talk about the deficit symptoms and signs that can be associated with Parkinson's disease and related conditions, dementia with Lewy bodies. Everyone knows the symptoms of Parkinsonism. So that's the tremor, the rigidity, the slowness. But in the later stages of people who suffer from Parkinson's disease, you can also see cognitive impairment. And here I write the term dementia, and sometimes dementia has a bit of a derogatory term, but dementia, all it means is having cognitive trouble or memory troubles that affect an individual's day-to-day function. So the ability to go out and plan what they want to do throughout the day becomes impaired. So that's what dementia means. So I'll be using the term dementia and cognitive impairment interchangeably throughout the talk tonight. So in the center of the triangle, in the group of the entire group of disorders known as Lewy body spectrum disorders, we'll talk a little bit about cognitive impairment associated with these diseases. When people have cognitive impairment in Parkinson's disease or in a related condition called Lewy body dementia, it can fluctuate. So sometimes during the day, the person suffering may be able to think clearly and talk and maintain a good conversation, and then other times during the day, fluctuations can happen where there will be confusion and disorientation to the surroundings. On the top of this triangle, I also want to point out another important group of non-motor symptoms, and this is the psychotic symptoms. This manifests as hallucinations, most common visual hallucinations, where people will see animals or other people in the house, and sometimes it may be frightening, sometimes it's not, and delusions, and this represents problems with thinking, where people may feel that things are being stolen from them, where they may be suspicious of their partner because they may be having an affair. So this is the delusions. And I put this at the top of the triangle because these are the overactive symptoms. You can think of deficits in thinking and deficits in movement symptoms and other symptoms associated with Parkinson's disease at the lower end of the triangle, and at the top end you can think of the overactive symptoms. So really you have a group of disorders where you see, deficiencies in activity, in performance in day-to-day lives, and then too much activity that can also produce problems. And this poses a challenge for management of the disease itself. So I want to introduce this concept of the Lewy body spectrum. So Lewy body spectrum disorders are a group of disorders that includes Parkinson's disease with dementia or cognitive impairment, and dementia with Lewy bodies. Okay, so all of these diseases can occur along a spectrum. Parkinson's disease in the earliest stages, patients, as you know, people will have trouble with movement. So this is where the tremor, the stiffness can emerge, and then the slowness of walking. In the later stages of Parkinson's disease, usually after many years of having the disorder, people may suffer from cognitive impairment and hallucinations. Therefore, the diagnosis changed to Parkinson's-related dementia or Parkinson's-related cognitive impairment. Finally, another disorder called dementia with Lewy bodies presents early on with dementia and hallucinations, and may also have Parkinsonism in the early stages, or may develop shortly after the onset of the cognitive impairment and visual hallucinations. So these disorders occur along a spectrum, and what the take-home message is from this is that early Parkinson's disease is mainly movement, although there are other non-motor symptoms which I'll talk about. Later stages of Parkinson's disease, you can start to see additional features in addition to the movement, and that may be cognitive impairment and hallucinations. And then in a related condition, you see things in the opposite direction, or simultaneously all at the same time, where you see cognitive impairment, hallucinations, and movement. So did everyone follow that slide? I just want to make sure that I'm being very clear. And if there's something that's, I know we're not allowed to ask questions, but if you want me to go over something, I prefer people to understand exactly what I'm saying, so that when you do ask questions later on, I can better answer them. So we'll first just briefly touch on Parkinson's disease, which I think a lot of you here tonight have had a lot of exposure to through other talks sponsored by Parkinson's Society, and also through your own experiences with the disease. So everyone knows that the earliest symptoms typically are the resting tremor. Usually it occurs on one side of the body rather than the other side. People may also suffer from gait troubles, so troubles walking. They may shuffle, they may stoop over. Rigidity can be manifest as difficulties doing up buttons or difficulties doing up zippers, so the stiffness in the muscles that people may experience. And then in the later stages of disease, people may be rendered immobile, so they may be confined to a wheelchair or have to rely on walkers and other assistive devices. And this is just an acronym, a group of acronyms that we use to, as doctors, to remember the different symptoms that can be seen. And I won't go over all of these. TRAP is the most common one that people have heard of: tremor, rigidity, akinesia, which just means slowness of movements. Bradykinesia is also slowness of movements, and then postural changes like stooping over. But you don't hear a lot about the other letters that are represented here. So D can stand for depression, and it's not uncommon that many patients during the course of Parkinson's disease will develop mood symptoms, and I'll get into the reasons why these may be seen later on. Sometimes also depression can be a warning sign that Parkinson's disease is coming on, and it's not uncommon that people are followed for many years by their family doctor or by a psychiatrist, for example, because of mood symptoms, and then slowly people begin to notice a loss of expression on the face and the troubles with walking, and so therefore the diagnosis becomes Parkinson's disease. Dementia is usually not typically seen at the early stages of Parkinson's disease, although it's very common for people to have cognitive symptoms at the early stages of Parkinson's disease. This is usually manifested as sometimes trouble finding words, troubles following conversations when there's many people speaking. And so you can see some cognitive impairment in early Parkinson's disease. But some people may present with Parkinsonism, hallucinations, and cognitive impairment that impairs function. And that diagnosis is called dementia with Lewy bodies. So be aware that the dementia can occur at any time during the course of Parkinson's disease, and if it occurs early, the diagnosis is different, although the diseases themselves are related to each other. Everyone knows the loss of expression on the face, the decreased blinking of the eyes. Patients may have trouble with swallowing, drooling, and low voice. Dream behaviors is another important group of disorders that can be associated strongly with Parkinson's disease and its related group of disorders, the Lewy body spectrum disorders. It's not uncommon where people may be acting out their dreams, because normally when you have dream sleep, what happens is your body shuts down and you become paralyzed. And everyone's probably had the experience where they wake up in the middle of the night and for a second they feel like they're paralyzed. That's because they're waking up in the middle of a dream. In Parkinson's disease and in dementia with Lewy bodies, the ability to suppress that ability to become paralyzed while you're dreaming is lost. And that's why you may see people acting out and thrashing around at night and talking in their sleep. So that's called rapid eye movement sleep disorder, or just dream enactment, is what I'm calling here. Sometimes that can happen during the course of Parkinson's disease after it's diagnosed. Sometimes it can predate the symptoms of Parkinson's by more than 10 years. And there have been some studies that have shown by 30 or 40 years, but that's less common. Another, everyone knows the gait troubles. Usually the gait troubles at the early stages of Parkinsonism are related to kind of slowing down of the walking, but usually people don't have falls at that stage unless they trip over something. But in the later stages of disease, the gait troubles can progress, and then the balance actually becomes affected, and therefore people may require assistive devices. There's a small writing. Skin changes can also be seen in Parkinson's disease, where people have very oily skin with seborrhea. And then in the later stages of disease, or sometimes as a side effect of medications, people can see low blood pressure when they get from a lying to a standing position. They can feel very dizzy. This is an early feature of dementia with Lewy bodies. So moving on, in order to diagnose Parkinson's disease, you have to have resting tremor and one of two of three features, resting tremor and rigidity, that has a good response to the anti-Parkinson's medication. So these are the medications like levodopa. In terms of Parkinson's disease, it's a very common disorder. It affects more than 100,000 Canadians. The prevalence or the occurrence over the age of 60 is about 1% of the population. And more than 90% of people in Ontario are over the age of 60 with the disorder. So aging is the biggest risk factor for developing Parkinson's disease, but also for developing other kinds of changes in the brain like Alzheimer's disease, where memory is an early and prominent feature, and also with Lewy body dementia. So if I see someone in the office that has some of these what I call atypical features, so they have symptoms of Parkinson's and signs of Parkinson's, they have a tremor, they have stiffness. If there's a history of early falls, if there's a bad response to levodopa, if the presentation is more symmetrical at onset, meaning affecting both the left and right side at the same time, if there's a rapid progression in the course of the disease, and if there's a lack of the typical rest tremor, then I start to think that the person may not have Parkinson's disease and may have one of the related conditions. And I'm sure that many of you have heard of the Parkinson plus conditions. So that's Parkinson's plus some other features. And Lewy body dementia falls into that spectrum of conditions. Also, if there's early problems with blood pressure going low, then that's also an indicator of another condition that needs to be looked for. So everyone remembers that in the brain, dopamine is running a bit on the low side, and this is responsible for many of the symptoms related to the motor side of things. So the tremor, the stiffness, the slowness of walking. And this is because there's a part of the brain that where the dopamine cells are produced that starts to, the cells are lost. And in losing the cells, you lose dopamine in an important part of the brain called the basal ganglia, which is the motor system of the brain. But we have to keep in mind that Parkinson's is more than just dopamine. There are many, many other brain chemicals that can be affected in Parkinson's disease. Another brain chemical in yellow is serotonin, and serotonin is really, really important for regulating mood and appetite. So serotonin can go low and can produce symptoms associated with depression, for example, or loss of interest and drive to do things. In green, there's another brain chemical called noradrenaline, which can also affect changes in mood and can also be responsible for the balance difficulties in the later stages of the disease. And then on this picture of the brain, so this is just a picture of the brain in multiple layers. This is a picture of the brain taken sliced this way. There's another chemical in blue called acetylcholine. And when acetylcholine goes low, that can be responsible for the cognitive symptoms of the disease. So we'll go through the cognitive symptoms a little bit in a bit, but I just wanted the take-home message from this slide and the preceding slides is that it's more than just dopamine, and therefore, because there's multiple brain systems involved, we sometimes have to target with medications the multiple brain systems. So I'll start to move into the talk about Parkinson's disease, cognitive impairment, and Parkinson's disease, dementia. Keeping in mind that, once again, dementia just means cognitive impairment or memory trouble that affects the day-to-day function and performance of kind of the things that we need to do to get our day-to-day things done, like banking, cooking, cleaning, etc. So in terms of Parkinson's related cognitive impairment and cognitive changes, about 40 to 50% of patients, especially if they have the onset older on, are at risk for developing cognitive impairment and possibly going on to develop dementia. So it's higher than we thought. About 10 years ago, as Sandy had mentioned, we were unaware of this problem, and only when more sophisticated studies were done, it was found that cognitive impairment associated with Parkinson's disease is actually not that uncommon. In one study, in fact, that followed patients over about 8 years, in their study, about 80% of people went on to develop cognitive impairment. So it is a real problem, and as we get better at treating the motor symptoms of the disease with the multiple drugs we have available, we're seeing these problems more frequently. Having Parkinson's disease does increase your risk about 6 times for the development of cognitive impairment. So it's not just the aging, but it's the aging that can be associated with Parkinson's disease that can increase the risk of cognitive impairment. How do you diagnose Parkinson's dementia? Well, as doctors, we like to make diagnoses. We have to keep in mind that this group of disorders occurs along the spectrum. But the way that we diagnose it is in someone that meets the criteria for Parkinson's disease, the tremor, the rigidity, the slowness of movements. They have a good initial response to the levodopa, and then more than 1 year after the onset of the motor symptoms, they develop cognitive changes. And the cognitive changes that can be typically seen are not exactly the same as what we see with Alzheimer's disease. You can see memory loss, but it's usually not the frequent repetition of questions over again every 5 minutes. Usually someone may ask a question and then ask it again, but if you remind them of what was forgotten and what they asked, it comes back to them. In Alzheimer's disease, we typically don't see that benefit from cueing or benefit from reminders. So it's a bit different what we see with Parkinson's disease. We see a lot of what we call executive dysfunction, okay? And what that means is that troubles with planning and organizing and structuring your day-to-day activities. So someone that used to be able to pay the bills and then get the grocery list and go and pick up the grocery list, all the groceries that are on the list, may develop troubles organizing and therefore cannot carry out. Or it may take longer to carry out. That's independent of the slowness of the movements. So there's also some slowness of thinking and of processing information as it comes into the brain. So once again, for Parkinson's-related cognitive impairment or Parkinson's-related dementia, the symptoms usually start more than 1 year after the motor symptom, and that's an important distinguishing feature. What are the risk factors for developing cognitive impairment associated with Parkinson's disease? Well, I mentioned earlier age, so having Parkinson's disease start at a later age does increase your risk for cognitive impairment and cognitive changes. Having any of the atypical features of Parkinson's disease, and these are the early balance troubles, the lack of benefit to levodopa early on, are risk factors for developing cognitive impairment. Having the disease for a longer duration of time increases your risk because the changes that occur initially in one part of the brain can progress to other parts of the brain, and I'll show some examples of that a little bit later on. Having more stiffness and less tremor is a risk factor. So the absence of the rest tremor is a risk factor for cognitive impairment. Now, these are all kind of rules, but they don't apply to every single person. So there are people that have tremor that can develop cognitive impairment, and there are people that don't have tremor that don't develop cognitive impairment. So these are just some general rules that we extract from studies, but they don't always apply to each individual person that suffers from this disorder. Having more motor symptoms or more motor disability early on and a rapid progression of the symptoms is a risk factor for that. Having confusion or hallucinations when levodopa therapy is started, especially when the dose is being built up, is a warning sign that there may be some changes in the brain that are predisposing to cognitive impairment. And then finally, having the onset of depression during Parkinson's disease is a risk factor for cognitive impairment. So I'm just going through some of the risk factors for Parkinson's-related cognitive changes, and I'll just continue on. So I'm going to shift gears now and talk about dementia with Lewy bodies, which I think is really, really important to understand as truly a related condition to Parkinson's-related cognitive impairment. So just in terms of the group of disorders of Parkinson's-related cognitive changes, as well as dementia with Lewy bodies, they form the second most common cause of cognitive impairment that's out there. The first most common cause is Alzheimer's disease, usually mixed with some hardening of the arteries. But Parkinson's-related dementia and Lewy body dementia form the next most common cause. So it is a real problem out there, and it's much more common than what we thought. Now, what are the central features of dementia with Lewy bodies?
So the central features are having criteria for cognitive impairment. So that's cognitive impairment that impairs day-to-day function and performance of the things that individuals may experience and have difficulties doing during the day. The core features of this are fluctuations in cognition and alertness. So sometimes people may be able to focus very well and maintain a really, really good conversation. And then other times people that have cognitive impairment associated with Lewy body disease, but also Parkinson's-related cognitive changes, may not be able to focus on what's being said and may lose track of the conversation more easily. Having visual hallucinations is part of the triad, and this is going back to the corner of the triangle, so the fluctuations in cognition, the hallucinations, and then having spontaneous Parkinsonism, meaning that there was no drugs given that can cause Parkinson's type side effects. And then there's a bunch of suggestive features, having early dream enactment or REM sleep disorder, rapid eye movement sleep disorder, and having sensitivity to a group of drugs that sometimes can be used to treat the hallucinations. And these are called antipsychotic drugs or neuroleptics. And common drugs that are in this category are like Seroquel, for example, or clozapine. So there's a lot of overlap between dementia with Lewy bodies, DLB, and Parkinson's-related dementia or Parkinson's-related cognitive changes. So from a thinking perspective, people that suffer from these disorders have the impaired executive functions. So the troubles with planning and organizing, with keeping things straight, with keeping things in order. This is a real problem once cognitive impairment starts with Parkinson's disease. There's slowness of speaking and thinking, so there may be a delay in getting the answer out. If there's impaired memory, but it's not the same type of impairment in memory that's seen with Alzheimer's disease. Usually this type of memory benefits from a reminder. Okay? There's impaired visual functions. So this is where the environment, for example, the home environment may actually look different to the person. So they may start to place, for example, milk in the cupboard instead of in the fridge, or ice cream instead of in the freezer, they put it in the cupboard. Because the visual world doesn't look quite the same. They may often go in the wrong direction in the house. Instead of going to the bathroom, which has been in the same place for the entire time they've been living there, they'll go in the opposite direction. And these are some of the things that people with the cognitive impairment will experience once Parkinson's disease progresses to this stage, if it progresses to this stage. There's impairments in ability to speak, so troubles getting the words out. Stuttering is very common with Parkinson's disease, but this is more than stuttering. They may actually lose train of thought when they're talking to people. There are a bunch of psychiatric features or neuropsychiatric features. So sometimes there may be some personality changes where people are more mentally rigid, so they can't adjust to new situations as well. And so when there's a change in the environment, or a change, for example, in the way that something is done, in the routine, it's difficult for them to adapt to that new routine. And that's a very common problem. There are mood and behavioral symptoms. So there's apathy, kind of withdrawal and loss of interest and motivation and drive to do things. Depressive symptoms, so having a low mood, having a loss of interest, can be associated with some of the behavioral symptoms and mood symptoms associated with Parkinson's disease and Lewy body disease. And then hallucinations. Now hallucinations, often the most commonly associated with Parkinson's disease and associated with Lewy body dementia, are usually visual in nature. So people may see things, and usually animals, usually kids, sometimes older adults in the house. Sometimes these are familiar people, sometimes they're not, sometimes they can be threatening, sometimes they're not. But a few of my patients who had Lewy body dementia could actually, instead of just seeing things, he would see little bugs, but he was able to grab the bug and to measure the tensile force that the bug exerted against his fingers. So these are just examples of that hallucinations can go beyond just seeing things. Sometimes people may hear things as well, and that can be distressing because it can produce confusion. You also have to keep in mind that you can't, I'm painting this nice picture that the memory symptoms and the thinking problems with Parkinson's disease are separate from the hallucinations. They're not. I mean, could you imagine sitting in a room and suddenly you see a group of kids playing in the corner of the room, and therefore you can't pay attention to what your spouse is asking you to do, for example. So it can be very distracting. So distractibility is very commonly associated with Parkinson's disease. And then obviously the motor symptoms, which I think is a unifying feature across Lewy body disease, the Lewy body spectrum disease. All of these symptoms result in a loss of ability to function in the day-to-day life. So how do you differentiate Parkinson's-related cognitive impairment from Lewy body disease? The only differentiating feature, in fact, is that the dementia symptoms occur after the motor symptoms by more than 1 year in Parkinson's-related cognitive impairment or dementia. In Lewy body disease, the dementia can occur at the same time as the motor symptoms, or, for example, at the same time, or can predate the onset of the motor symptoms. So that's really how we diagnose this in clinic. It's important to be able to diagnose this in clinic because it will change the way we approach the condition. For example, if I saw someone in my clinic that had Parkinson's symptoms, so they had tremor and stiffness, and it looked like Parkinson's disease, but I did cognitive testing in my clinic and found that there were impairments on the testing that we did. And these cognitive testing is essentially thinking tests that are done. We'll ask you to remember, 3 or 5 words. We'll ask you to draw a picture. We'll ask you to trace a pattern. This kind of testing, if I see significant impairments on that testing and I get a history from the family member that their thinking is affected and they're not able to do the day-to-day functions, well, my first course of action may not be to start with levodopa, because the levodopa may actually exacerbate these cognitive and memory problems and hallucinations especially. My first thought is to start them on another drug which will treat the cognitive symptoms and then introduce the levodopa at a later stage. So I really do think it's important to make these distinguishing features, even though we do them for our benefit. I think it also benefits the individuals who are afflicted with these devastating conditions. And just to remind you that the Lewy body spectrum, Parkinson's disease, Parkinson's dementia, and Parkinson's disease dementia and Lewy body dementia account as the second most common cause of cognitive impairment in the population. So what are some of the features that may distinguish some of the different dementia types? So I mentioned about Alzheimer's disease being mainly an impairment of memory. But this is an impairment of ability to store memories. So the memories never get in, and therefore you can't retrieve them. In Parkinson's disease and also in Lewy body disease, we see that the memory, in fact, goes in, but it may not be accessed. And that's why some family members will say to me, I'm surprised. Sometimes they can't get it at that moment, but an hour later, they'll pull it out, what we were trying to talk about. And that's because it went in, they weren't able to retrieve it. And that's because the front parts of the brain are affected in Parkinson's dementia and in Lewy body dementia. There are fluctuations in attention and concentration and these executive functions. These are usually a little bit less pronounced in Parkinson's-related cognitive change than in Lewy body disease, although it truly does occur along the spectrum, and many people that have Parkinson's-related cognitive changes can have as much trouble as someone with a diagnosis of Lewy body disease in terms of the executive problems, in terms of the maintaining focus, not being distracted by things in your environment. Hallucinations are common to both, maybe a little bit more prominent in Lewy body disease, but not everyone with Lewy body disease gets hallucinations. So I think one recurrent theme tonight is that there's a spectrum and we don't see all of these symptoms occurring at the same time in individual people. And so you really have to take a good history as a doctor and to do a thorough examination in order to kind of help sort things out. And this is how we can do it. So this is just a Venn diagram, so there's a bunch of overlapping circles showing the spectrum of Lewy body disease. So on one side,